How do you want to handle? Do you want to go through these questions at the end, or? Yep. Yep. Sorry. Thanks, Steve.
Thanks, Fiona. Thank you. Very kind words, and I appreciate the opportunity to speak to you tonight about OTC, the OTC sector, about how some of those things might be useful for you to know now. I think what I've tried to do here is capture a broad sort of snapshot, so probably won't go into anything in too great a detail, but give you a whole picture. And it may be best if we hold questions till the end. That way we can go through the presentation and then come back to any areas that are of particular interest. So thank you to Rosemary and to Peter for the opportunity to speak with you this afternoon, and thanks again, Fiona, for those kind words. The presentation will be made available afterwards. I've just got to get rid of some of the notes and PDF it up, and you can have it. So don't feel you have to make copious notes as we go along. And yeah, so we should still have plenty of time for Q&A. Going to try and manage a hard copy at the same time as the electronic copy. So hopefully that will work. Do I have to point it more directly? Pressing it. Oh, on. You sure? There's a lot of slides there. Okay, so what I might do first is give you a little bit of information about CHP Australia. So if you could move to the next slide. Sorry, maybe I could drive it from here if you like. So we're an industry body representing non-prescription medicine. So that's complementary medicines and OTCs. The whole market's worth about $8 billion in total. We have two types of members, ordinary members and associate members. And the ordinary members are those organisations which have products on the ARTG, so they're sponsors of products, or they have a product close to being onto the ARTG. And then the associate members, which are those organisations which provide support to the sponsors. So if we could move on to the two slides and then the next one. This just gives you a bit of a sense of the industry association landscape. Obviously, you need to update this to include MCIA, and it's not to scale. But what it's meant to do, I guess, is to show the overlap between all the different industry sectors and the different industry associations. So there are, the interfaces between food and medicine, for instance. And so we have a good relationship with AFGC, the complementary medicines and OTCs, the cosmetics and OTCs, the devices, there's a whole range of devices from stents and artificial joints all the way through to eye drops and band-aids. And so it's a fairly cluttered market. And, we like to think that our association takes care of any therapeutic good that you can buy without a prescription. If you can walk into a pharmacy or another retail outlet and buy it, then that's, that's for us to take responsibility for, because consumers don't care what regulatory pathway this particular product followed, or whether it's a device or a medicine or a cosmetic. They're buying a product for a particular use, and so that's the way we sort of approach it, the industry. So if I could move on to the next slide. Our ordinary members, you'll see some familiar logos there. And then the next slide after that is a list of all of our current members, ordinary and associates. So if we could move on to the following slide. So really, how do we help our members? It's about advocacy. It's about the support that Fiona mentioned. It's about offering a self-regulatory environment. And we do offer training and education. So if we can move to the next slide after that, and then the following one from that. So what I'd like to do, I guess, is to sort of set the scene for you as the way I understand it. Companies unfamiliar with the OTC industry, looking at moving into that area, or having recently moved into that. So it is complex. There is a lot of things that don't seem to make any logical sense. That there's not necessarily, it's not unnecessarily complex, but there's a lot of complexity, a lot of subjects and topics that interact with each other. You need to be able to find your way through. You need to be able to navigate your way through that. There's a lot of material you're going to have to be familiar with. And if you get it wrong, the consequences can be serious. There's recent announcements by the TGA about their advertising compliance actions with regard to cannabis recently and in the recent past as well. The other thing which strikes me as being important is that there's a commitment. There's a long-term commitment. You get your product on the register, and then you have an obligation to maintain that registration. You have an obligation to keep the TGA informed. You have an obligation to make sure that you are continuously complying with the rules as they are at that time, not necessarily at the time when you registered the product. So there's ongoing commitment. It is like having a long-lived pet, that you can't just get rid of it. You've signed up for this commitment and you've got that long-term obligation. So what if I can go through to the topics, the slide after that as well. So I'm going to skim through this. What I want to do is really sort of look at the scheduling path, sort of how you got to where you are today. Have a bit of a look at the marketplace that you may find yourself in shortly, and then sort of touch on some of the key topics in what I think is a reasonable order to approach it in. So get the important building blocks out of the way first, and then the sort of easier to manage technical aspects after that. So if we can move to the following slide and the next one. Thank you. So the scheduling path here. So for a lot of orthodox medicines, there's a pretty predictable scheduling path. You conduct your clinical trials, your preclinical, your later stage clinicals, you develop up a dossier, you get a set of patient population, a set of indications, dosages, known reactions, sort of common, less common reactions. You take that to the regulator. They allow access on a prescription basis. The product stays as a prescription item for a number of years. People become more comfortable with it. The TGA becomes more comfortable with the molecule, the stability of the molecule. Healthcare professionals become familiar with it. Consumers become familiar with it. And then if the indications and the substance are suitable, the product can then move down schedules. So from Schedule 4, prescription only, to Schedule 3, pharmacist only, to Schedule 2, maybe, pharmacy only, and then to unscheduled open sales. So there's this sort of fairly regimented path that most molecules follow. Now, CBD hasn't followed that path, and I'll take you through some of the recent examples. So if we can skip that slide because I've just gone through it. We can look at ibuprofen. Now, that was registered as a prescription medicine in 1969 here. It was switched to S3 in 89, and then to S2 in 95, and then to GSL in 2004. So this fairly ordered progression. So it's 20 years it's been as a prescription-only medicine before it moved down to S3. And those changes in scheduling are driven by the sponsor. They're based on, there's specific products in the market, specific indications, patient groups, and it's generally subsets of those that are moved down first. And everyone has developed a sort of a level of confidence with that molecule. There's no unexpected surprises. People, know. So ibuprofen, for instance, it's a good example. One ibuprofen product or another ibuprofen product or a third, fourth, 200 milligrams of ibuprofen, it's the same stuff. It's going to do the same thing for the same patient. So there's this level of comfort, I guess, and predictability. So like I said, the important thing there is really that 20 years that it's been as a prescription-only medicine. So if we could move to the next slide. And then the proton pump inhibitors, they took a similar path. So 1989, first one registered as a prescription medicine. 2008, the first one registered as a S3. Similar profiles again, it's driven by sponsors, the product's well known, subgroups move down the risk platform, and that's 19 years as a prescription medicine. So we can move on to the next one. So the CBD scheduling history, it's a lot more nuanced, I guess, might be a useful word there. The important thing here is the new S4 entry for CBD in 2017, followed by the new S3 entry in 2000. So that's only 3 years. So the TGA hasn't developed confidence or expertise or understanding. The healthcare professionals haven't had the same, amount of time to deal with it. The industry itself hasn't had the same time. You think it's not this steady, ordered, stepwise progression, and I think that's going to create a number of difficulties for companies. So we just move to the next table. I think this is a useful summary of all of the preceding ones, and that the drive to move to lower schedules for ibuprofen and the PPIs came from the companies. And so they know what they're looking for. There's a consistency amongst the indications, a consistency about the use of the product. They're based on traditional drug development processes. And, there's lots of sponsors, but they're all talking about the same thing. Whereas with CBD, there's at the moment, an unknown number of sponsors or potential sponsors. Who knows what they're talking about? Who knows what trials are being developed, where the products are going to go? So I think this adds to the complexity. It adds to, I guess, that level of uncertainty about where it might go. And worth bearing in mind that scheduling change for low dose CBD came from the TGA. It didn't come from sponsors. So it's like the TGA is giving people something that may not necessarily suit their needs. Whereas in the other examples, the companies were asking for something that they knew that they wanted, they knew how to deal with, they had plans for. So now that we're here, what does that actually look like? So we can move to the next one and the one after that. Thank you. So the scheduling entry itself. Now I've highlighted some of the specifics of this entry. This is a really, really complicated entry. You've got information there about the composition, the route of synthesis, the dosing, the age range of the patients, the pack sizes. Normally, if you look at it, say a paracetamol or ibuprofen scheduling entry, it's pretty straightforward. It says less than 500 milligrams in a pack size of 20, done. Whereas this is really complicated, and every single one of those requirements has to be met for your product to be an S3. So we can move on to the next one. So what I wanted to do here was to sort of look at where CBD might go from an OTC perspective. And really, these are my musings. These are not based on any intelligence that I've received or obtained or looked at. This is just my sort of best guess about where the data might take some people. And I think the thing to remember here is that the indications that you choose are going to have to match the TGA's risk-based approach to regulation. So you need to think about indications that are OTC appropriate. So, the condition can be understood by consumers, it can be managed by consumers, that the molecule itself, the safety of the molecule is managed in a particular way, or the safety of the product in this case. So you've got a particular, I guess, stratum of indications that you can play around with. And I thought it might be useful to have a look at that market. So on this slide, you can see prescription and non-prescription, we're looking about 60-40. The majority of medicines sold in Australia are prescription medicines. But that's not much. It's not by much. It's not an overwhelming majority. And then looking at the channels, the bulk of the channel is through pharmacy. Some grocery, about a quarter, and then a very small proportion through e-commerce. So we can move on to the next slide. This is just the breakdown between OTCs or orthodox medicines and complementary medicines. So complementary medicines, you think vitamins, minerals, supplements, marine oils, that sort of thing. The whole OTC market is worth about, I think, so 7 billion, and 1.7 billion is made up of complementary medicines. And then if we can move to the next slide. The categories that I wanted to look at that I thought might be relevant were pain, sleep, and stress / anxiety. And to give you, rough figures there, it's a bit over, $1 billion there. So maybe a seventh might be what you're looking at of the total market there. So if we can move on to the first one. So looking at pain and inflammation, there's no easy way to find out what the products are. So, I just did a quick and dirty look at the Chemist Warehouse website and just put in some search criteria there. So you're looking at $730 million worth of products and, over 200 products in the analgesic, anti-inflammatory, heat rub segment or group. And from an OTC point of view, you're looking at, common things: paracetamol, ibuprofen, diclofenac, naproxen. Some interesting things in the complementary medicine space too, turmeric, oleoresins, but this Palmidrol PEA, I've seen a few ads for that product recently, and that taps into something that I think might be useful, where you're looking at product specific data rather than sort of generic data that might apply across a range of products, and interesting range of formats there. So, these are all sort of fairly common brand names, Panadol, Nurofen, Advil, those sorts of things. And then the Palmidrol product is an ethical nutrients product that I've seen a fair bit of advertising for lately. So if we could move on to the next slide, which is looking at sleep. The other category I thought might be of some interest for CBD. You're looking at 115 million. Once again, and Chemist Warehouse website, 123 products, and interesting, a decent mix of OTC and comp meds there. So the standard OTC, first generation antihistamines, so doxylamine like Restovit, Dozile, those sorts of products. But then also the more recent downscheduling of melatonin for a very specific sleep indication, but something of interest there. And then there's a whole range of complementary medicines that are promoted for sleep. So these are the sorts of products that you could potentially be competing with if this was a segment that was of interest to you. So if we could move on to the next one. And then the last one I wanted to look at was anxiety and stress. And I found this category particularly interesting because there weren't any OTCs here at all. But there's plenty of complementary medicines. Now, because of the TGA's regulatory environment, those complementary medicines are all put forward as being for mild conditions. So, the stress relief, calming, focus, energy, anything to do with anxiety has to be qualified by, mild. Because bearing in mind that listed medicines are meant to be the lowest possible risk medicines in the marketplace. So there's no risk with consumers misdiagnosing, no risk with them misunderstanding their symptoms or using products inappropriately. And so, but interestingly, how many products there were in the comp med section? No. Yeah. So. Good. So yeah, I thought that was an interesting category to look at as well. So so what I'd like to do now is if we move on to the next slide after that. So to go through some of the topics, the specific topics. So the principal legislation that you'll need to be familiar with, the Therapeutic Goods Act and the Therapeutic Goods Regulations. So basically, that's the legislation that sets the TGA up. It sets up what they can and can't do, what they can and can't ask you, what they can and can't expect that you will do with your products. But you do need to be aware of some of the state and territory legislation, particularly around storage. And the scheduling itself is really this complicated mix of state and territory implementation of a suggestion by the Commonwealth. But we could spend all night talking about that. We won't do that. But you do need to be aware that there is other legislation apart from those two principal therapeutic goods pieces. So looking at the next slide up, TGA processes. So there are regulatory guidelines for OTC medicines. The TGA have spent the last couple of years tampering with the format of that and also playing around with some of the content. So what we've tried to impress upon the TGA is that from a regulatory perspective, it's nice to have a complete set of the requirements as they are today, because that's what I'm making my decisions on today. And if they change in 6 months and someone wants to know why we did something a particular way, I need to be able to go back and say, here's what the regs look like in, June 2019. So the TGA are attempting to do that. They're attempting to be better at their version control, which is a hilarious topic in itself. They just trying to keep track of that is really, really quite difficult. So the guidelines are there. You can print them out section-wise. It's meant to be set up to guide you through as a novice. It doesn't always work. The interesting thing, I guess, for today is that for new product registrations, there's 5 categories, N1 to N5. And for changes to those products, there's 5 categories as well, CN through to C4. The thing that will be relevant here, the category here is N5. So you'll need to establish to the TGA's satisfaction that the quality, the safety, and the efficacy of your product is acceptable. So your dossier will need to be will need to satisfy the TGA of those attributes, and you will need to use CTD structure. That may be, it depends where you are. As a new company starting out, that may not be a problem. It's generally more of a problem for more established companies who've got archives in different formats and different structures to move it across. But it's worth noting that the TGA does have the CTD structure. Okay, so it's a common technical dossier or common technical documentation, and it's 5 separate volumes where you place the different data module, and then module 1 through to 5. Module 1 is the market specific stuff. So if you've got a dossier that you've inherited from overseas, you'll still have to prepare up that first module, module 1, which is all the market specific stuff like labeling and the specific TGA information. So it's a supposed global process for harmonizing the way dossiers are put together. And there's a whole bunch of other specific guidance that the TGA put together on specific topics, but ARGOM, or the regulatory guidelines for OTC medicines, that's the place to start. So I might move on to this slide. So the first thing you're going to need to do is to talk about or think about clinical trials, and many of you may already be well down this path. And this is incredibly complex, and it's something that you have to engage experts on. The study design, the population, the size, the endpoints that you choose, the secondary endpoints that you choose, all of those are going to be critical to convincing the TGA that your product will do what you say it will do. So you'll need to look at, the safety aspects of those trials as well. I think, you need to engage experts here, and you may need to call on those experts if the TGA push back on any of your data as well. So that's worth bearing in mind too. The other thing with the clinical trials, and I sort of touched on it earlier, is will your trial establish that it's your specific product that has this particular effect? So is it going to be like that Palmidrol PEA? Is it going to be like some of the other marine oils where the sponsor says the outcome that was achieved is a direct result of this specific extract, this specific treatment, this specific product, and so no other sponsor can rely on this data, no other sponsor can benefit from it? Or is it going to be data along the lines of paracetamol data, ibuprofen data, which is basically 500 milligrams of paracetamol, everyone's paracetamol is going to be the same. This data basically just enables any sponsor to say the same things that I'm saying. So they're I guess, the important things to bear in mind looking at that, and the indications, as I mentioned before, tailoring them to the TGA's risk-based framework. So and I'll move on to the slide after that. So the next thing you're going to need to do is to get a manufacturing site that will be acceptable to the TGA. If you don't have an acceptable manufacturing site, you won't get your product on the register. You won't even get past go. That's a fatal problem for any application. The TGA have two different paths for local manufacturing. On the one hand, the TGA need to come out, have a look at your factory, satisfy themselves that everything's okay, and then give you a license. For overseas sites, there's a couple of different pathways depending on whether that site's located in a market that the TGA has confidence in, or whether it's located in another market where one of the regulators they've got confidence in has come from. So you can get those overseas sites done or approved through a desktop audit or DTA process, which is a paperwork exercise. Basically, you put together a dossier, you send it to the TGA go through it. Their friends in the UK have been there, so they're happy with it or not. If you can't access either of those DTA pathways, then the TGA will have to go to that site, which then becomes complicated in terms of scheduling the trip, financing the trip, waiting for the trip to actually happen, and all the while, you can't use that site to make product or to register product. So that's the important thing. The other thing, I guess, the learnings here for the TGA during COVID is that they've been able to use some of the virtual techniques that businesses have been using for meetings and that to virtually inspect some sites. So they've been able to cut down on the travel and the physical presence in factories by using some of these virtual techniques. So, and then the next one, so the raw materials that you use and your finished product are going to have to comply with standards expected by the TGA. Now, they're usually, so the BP and the EP and the USP, but if your ingredients are not in either of those pharmacopoeia or your finished product isn't in those pharmacopoeia, you need to come up with a non-pharmacopoeial standard that will satisfy the TGA. And that gets complicated when you've got lots of sponsors with lots of different products that all want to have lots of different non-pharmacopoeial standards. So it can get a bit messy there, but I won't spend too much time going through that. The next one is variations. So once you've got your product registered, it's, you've got the data to support it. You've got it on the register with the GMP approved manufacturing site. If you make changes to that product, you've got to tell the TGA about it. If changes are made to those pharmacopoeial standards, then you've got to tell the TGA that you've accommodated that change or made that change. And there's a range of variations that you can make that either require no notice to the TGA all the way through to TGA approval before you can implement it. We might move on to the next one after that. So labelling. So there's a few different things here that have an impact on labelling, and these are just the TGA requirements for labelling. There are other requirements. So retailers will have requirements around the barcodes, some of the physical attributes of it. There may be other things that you want to include on the label. Country of origin's usually a good example there that aren't strictly controlled by the TGA. The TGA don't have any guidance on that, but you still need to be compliant with the relevant requirements there. So the things to bear in mind here, the RASML or the required advisory statements for medicines labelling, the Therapeutic Goods Order 92, which sets out the label requirements for OTCs, and then the product information and the consumer medicine information documents. I won't go into any of those in detail, but we might just skim through the slides just to show you that. So the requirements are there. All of those labels have to be there. There's a CHI or critical health information panel that all OTC medicines have to have. And, this is it's not quite the same, but similar to the US drug facts style labeling, where the back of the pack has a sort of a sameness across medicines so consumers can find medicines information quickly. The next slide on RASML, the thing to touch on here is that there aren't any statements in RASML yet for CBD. So when the first sponsor gets their label approved by the TGA, there will no doubt be warning statements on it. Now that will in all likelihood trigger Erasmus consultation, which will then result in mandatory warning labels for future CBD products, but that will also have an impact on that first sponsor who may then have to change their labels. So the labeling that the TGA approved may contain different warnings to what comes out of the Erasmus consultation process. So that's something to bear in mind, that even if you are the first mover, you still may have to go back and change your label warnings. And then the PI and CMI, these are documents for consumers and for healthcare professionals that lay out in a non-promotional sense the various attributes of the product. And I might go to the next slide. And yeah, there are templates for the CMI, and the useful thing is that there are different templates for prescription and non-prescription medicines. So because those medicines are used differently and they generally have different risk profiles. So I might move on to the next topic. So advertising, I think after the clinical trials, I think this is the next sort of really hot topic, I guess, to be the major area of uncertainty too. At the moment, as an S3 product that's not in Appendix H, CBD can be advertised to, or low dose CBD can be advertised to healthcare professionals, but not to consumers. And then the next question is, well, what is advertising? And you see a lot of people get caught out either, innocently or recklessly, or maybe even intentionally by, not understanding what advertising is and thinking that they're just, making some comment about the company's investment strategy or, their new offices or something like that. So you need to be careful about the definition there. And the really important thing to stress here is that the cannabis and related products are a TGA compliance priority for advertising. So there's been plenty of announcements, there's been plenty of notice, plenty of meetings, plenty of advice from the TGA. This is one of the areas that they really want to focus on and I guess demonstrate that they are an effective regulator. So I might move on. Okay, so this is the thing that I really want to dwell on. I've got some other excerpts from the Act, but I won't dwell on that so much. So this definition of advertise is incredibly broad. So it's any statement whatsoever that directly or indirectly promotes the use or supply of the goods. So it's any statement that indirectly promotes the goods. It's incredibly broad. And so you are not allowed to make any statement like that to consumers. If you had a CBD product on the register today, you wouldn't be allowed to make any of those statements to consumers. And I think that's what catches people out. They think, oh, this is not advertising. It's not a 15-second video on the TV, so it's not an ad. But this is the definition you've got to work to. So the next slide, Section 21B4. This is interesting because it's an advertising requirement that sits outside of the main sort of advertising structure within the Act. And so this applies to advertising directed to healthcare professionals as well as advertising directed to consumers. So the other section, the sections following 42 do not apply to advertising to healthcare professionals, and there's a whole list of healthcare professionals in the Act. So, but this is important because anyone can get caught with this going to any audience, and that's promoting for an indication that's not on the register. So it could be that you are promoting to an age group that's not that hasn't been approved. It could be that you're promoting to an indication, or you're making a claim that's slightly outside of the indication that's registered, but innocent, or it could be completely off indication, like a completely unrelated claim that someone's making about your product. Bearing in mind that even if it's a statement that could indirectly influence the supply, so there's a lot of traps here for people who aren't really paying attention to the communication. So the other sections, the following ones, just to show you that you're not allowed to advertise a Schedule 3 medicine. The next section is that you're not allowed to advertise a product that's not in the register. So you need to be careful when you're developing products, when you're getting ready to launch products, when you're getting ready to register products. You don't have a product on the register, you can't talk about it. So, and then 42B. So there's some wiggle room here. So generic information. This is where prescription medicines you make so disease awareness campaigns, company statements, and that sort of thing. So this is an area you can play in, but it can't be promotional. It has to be about the substance rather than the product. It has to be factual rather than promotional. But there is, so if you think about the ads that you may have seen for prescription medicine disease awareness campaigns, that's the sort of stuff you can look at there. And then just the following section, that is that some of the therapeutic goods advertising code requirements does apply to generic information as well. So it's not open slather. You do need to have a look at those, the requirements in the regs. And that's just those sections. Those sections of the TGAC are what applies to generic information. So some further notes on advertising. Once again, you know, I can't stress this enough. The TGA are looking at this category intensely. This is one of their focus categories. The way that you assess the compliance of an ad is on the basis of the reasonable viewer. The TGA's approach is, what would the reasonable viewer of this piece of material conclude or take away or draw? You know, what conclusions would they draw? And the TGA, possibly helpfully, possibly not, distinguish between promotional and non-promotional, and they've put out some guidelines on, you know, ASX statements, for instance, on advertising or statements about medicinal cannabis that are compliant or non-compliant. They're a useful starting point, but they're not detailed enough. I don't think they're not really that helpful. So once again, you need to be really careful what you say. There are some things you can say, but there's a lot you can't. And then advertising to healthcare professionals, there are requirements here in the Act and the regs, and also under consumer law. I mean, doctors, in a therapeutic goods sense, doctors are not consumers, they're healthcare professionals. But from an ACCC sense, doctors are consumers just like their patients. So there's confusing language there, but you need to be careful with that you're not misleading doctors with the material that you produce. Once again, so digital and social media, the requirements don't call out specific media types or media formats, but digital and social tend to be quite problematic for our members and for our non-members as well, where, you know, what is digital advertising? You know, influencers, are they paid? Are they not paid? Are they given incentives? Are they not? You know, what can they say? What can't they say? You know, what about, you know, user-generated content? You know, who's responsible for that? So there's a lot of stuff that needs to be unpacked there, even though the requirements aren't media specific. And then advertising to consumers. So if or when low-dose CBD gets an entry in Appendix H, you'll need to be familiar with the Act and the regs, obviously, consumer law as well, but then there may be industry codes. If you belong to an association, there'll be a code of practice. There's also media codes like the AANA code of practice. And then you've got the therapeutic goods advertising code, and then you've got the TGA guidelines. My word of caution about the TGA's advertising guidelines is that they are self-serving. The TGA tell you you've got to jump this high. The law says you've got to jump this high. So if you agree with what's in the TGA's guidelines and you're happy to follow them, then you will be almost completely safe. But that's not a good measure of what the legal requirement or the regulatory requirement actually is. So the next slide here. So the difficulties that our members are having with that advertising code are around testimonials and endorsements, and, you know, what amounts to valuable consideration? What about sampling? What if you give consumers samples and they give you solicited and unsolicited testimonials? Can you use them? Can you stop using? Do you have to stop using them if you subsequently film one of those consumers? It's really difficult to unpack what the TGA's requirements are there. And once again, digital and social media. So I wanted to sort of begin to wrap up by thinking about some of the future changes that you might have to think about now. I mean, there's not even a product on the register, but there could be, future scheduling changes, either, to different scheduling classifications or to different appendices, or there may be changes to the Schedule 3 entry itself to make it maybe less complex. And then once again, inclusion in Appendix H, but also other regulatory changes. So the TGA are going through a digital transformation program at the moment, where they're looking at some of their processes, they're looking at the way they present their data. So things are changing in the background at the same time you're trying to get your product through the TGA's sausage machine. So you've got to sort of keep an eye on what's happening there, as well as moving your product through. So what I wanted to touch on lastly is maintenance. So you've got your product registered, you've got it, it's all labeled up, it's on the shelf, you're advertising it, everything's going fine. You now need to keep the TGA informed. If there's any changes to the safety, the efficacy, or the quality of that product, you've got to tell them. If you get any pharmacovigilance signal, either from adverse event reporting here, or online reporting elsewhere, solicited, unsolicited adverse event reporting, you've got an obligation to monitor overseas journals and publications. So if anything happens, you've got to tell the TGA. They expect that you have record keeping, appropriate record keeping, a complete comprehensive pharmacovigilance system, and that you monitor and collect information relating to the quality, safety, and efficacy of your product. There are recall obligations you need to be mindful of. You need to keep on top of those quality standards for your raw materials. You need to maintain your GMP clearances and licensing for those sites too. So it's not, you don't just get your site approved and then it's right to use forevermore. The TGA will want to come back and look at that site periodically, and they have a bit of a flexible scheme there, which is, the better your site performs, the less frequently they want to come out and see you. If you're only just getting through, then they'll come back and see you in a very short space of time. But if you're doing really, really well, the site's fantastic, no major issues, then they'll give you a bit more time before they come back. And once again, using Australian sites creates certain problems, but using overseas sites creates potential delays. And, if the GMP for your site expires and you can't get the TGA out there, then product coming out of that site's now compromised. So, and then there's annual fees, obviously, for the product. So just to conclude, just in that last slide. So these are all the topics that we've just gone over this afternoon. So there's your product, and then all of these things that you need to be mindful of, and you need to continue to turn your mind to throughout the life of that product. And so that's the final slide. I'm happy to leave that one up if you want, or we can go with that one. Yeah. Thank you. Yes. Hey.
Thanks, Steve. That was awesome. I've got two questions, if I may. First one is, you mentioned about labeling requirements being updated to, you mentioned CBD, the first S3 CBD product will need to include warnings that don't exist yet.
Yep.
Would that process delay the first products coming to market, or would that only require that product to make further changes once it's on the market?
Yeah, so that'll be taken care of in that first product's registration. So the TGA will sign off on the labelling, and you'll be right to market with that. And then if there is a consultation, the consultation may produce exactly the same warning that you've got now, fine, or it may produce a different warning or additional warnings, and then you'll have a transition period to accommodate that. So
the consultation process will have to parallel, doesn't have to be sequential and push out.
No, your product will go through unimpacted by the RASML consultation, and it'll come out the other end. And yeah, and then RASML will happen separately.
And my second question was, it's clearly extremely anomalous for the TGA to down schedule a products, A, by themselves as a delegated initiated proposal, and B, without any, schedule 4 product or limited schedule 4 products.
Yep.
Well, what does that tell you about how the TGA feels about low dose CBD?
Yeah, look, the scheduling processes, they are fairly opaque. There is a consultation process before an ACMS meeting. There is a consultation process on the interim decision. But the process that takes place at the ACMS is completely opaque. So you have the committee of experts who look at all the submissions, they look at all the feedback, they provide some recommendations to a person in the TGA, and it may not be the same person every time. And that person then forms a view and creates that interim decision. So it's difficult to speculate, but my personal view, and I have to stress it is my personal view, is that it was a political decision driven through public awareness. Now, the TGA says, and the legislation says, that the delegate makes their own independent decision, but the delegate is a person who lives in the real world like the rest of us, sees the same things we see, is exposed to the same things we're exposed to. There was similar decisions around nicotine and alkyl nitrites, where there was, publicity, there was consumer healthcare professional agitation. Something had to be done. What are we going to do? Well, let's do this. And then, I've done my job, I've rescheduled CBD. What more do you want me to do? But yeah, like I said, that's my personal view. So yeah.
I mean, we know there was a huge amount of public pressure. There were 2 Senate inquiries. They had to be shown to do something. What was really unusual, I think, is the scheduling committee actually recommended against it, and the delegate overturned it. So it just showed you how much pressure I think PGA were under to do something. But then they sort of had a bit of a ha-ha moment, possibly by saying, but you've got to get it registered on the ARTG as an OTC product. So that, made it hard. You can have it, but it's not going to be easy to get there.
Steve, again, great preso, and I know this would be your personal opinion, but do you think CBD is going the way of paracetamol? Or is it going to be we know there's a few companies now doing the pivotal trials, maybe news early next year. Will they be product specific registrations? And then do you think it'll be a wait and see before the TGA might make it a category? Because I see it being, isolates and full spec. And are they the 2 categories? Or are they all different because there's, a tiny minuscule amount of terpenes left in some oil caps only?
Yeah, and I think that's an interesting angle to this that isn't or hasn't been present in other categories or other substances before. I mean, the closest I can sort of come to it is around some of the marine oils. So, fish oil, krill oil, whatever the squid oil is, got a different name. The sponsors, the people who ran the trials have been very clear that this is what makes my product fantastic and unique, and here's how it's different to every other product on the market. And so, genuinely, the data only reflects this. And I think, paracetamol and ibuprofen, there's TGA have monographs for those products. It's because they know how it behaves. They know from a stability point of view as well as from a pharmacological point of view. I think a lot's going to depend on how the sponsors approach their data package, how they put it together, the arguments that they make. But the TGA are still going to have to look at every subsequent application. So say, you put in an application, it's got this data here, you say, this is our product and it's special because of A, B, and C. and the TGA agree with you and they, grant you those indications. I've come along, I don't get any benefit from the fact that you're already on the market. I still have to prove to the TGA that my product, has suitable quality, suitable safety, suitable efficacy. So I still have to produce a data package for the TGA.
But it's not a true de novo, like,
Well,
is it? Because
well, it depends. I mean, are they relying on your published studies for their application, and that's all they've got? I'd say that might fail. They're going to have
so
to
in terms of
produce.
piggybacking off other companies' clinical trial data, doing a, lighter touch,
Yeah.
smaller
I don't see that
sample
happening
size. Yeah.
anytime
I mean, I
soon.
don't either,
Yeah.
but I'm interested.
Yeah. Yeah. Yep.
But even an isolate has to be delivered in a format of some kind, right? Like you can have an isolate in a pressed film, which is different from a gel cap.
Yeah, yeah. And, there's some OTCs so topical OTCs, where the dosage form itself, as you say, does contribute to the efficacy. Some of the topical creams, they have special formulations and, they create faster absorption, for instance. And so that's a specific claim. I mean, if it's a pain relief cream, the indication is still the same, relief of pain, muscular pain, whatever. But there's some advertising claims that can be made around the specific delivery format. Yeah.
Just further to that, we actually took a delegation to the TGA with Professor Ian McGregor to see if we could put forward the concept of doing a generic study and relate that to real world evidence. And the summary of a 1 hour meeting with the TGA was, nah. So
Yeah.
that's the issue, is that it is very specific. And they went straight back to it's the presentation of the product and it's product specific.
Yeah. Yep. And it's the newness of it all too. So yeah.
And if you want to make a claim, able material, then you've got to be able to prove those claims.
Yeah. Yeah. That's the other thing too. If it's a registered medicine and the TGA have approved the labeling and there's a claim on the labeling, that makes that claim much easier to defend, because you can't have a claim on the label unless the TGA's been satisfied that the data's there. So that's a good tactic if you've got something in mind to have it put on the label, and then it's hard for people to argue that there's no evidence.
I'm loud enough. For the recording. Yeah, absolutely. Off-label access to OTC medicines. I'm imagining a scenario in which a CBD product gets registered for a specific indication as an OTC medicine.
Yep.
But people who just want CBD for whatever reason they happen to want it for will try and access it, even though they aren't accessing it for the purpose for which that drug has been registered. In a situation where a patient or a consumer walks up to a pharmacist and says, "I'd like some CBD, please," the pharmacist goes, "What's your situation?" And they go, "Oh, I've got pain." Does the pharmacist then go, "Sorry, this is only appropriate for sleep, go away"? Or would they in practice be a bit more flexible, do you think?
Yeah, that's a professional standards matter, and I'm not really qualified to answer that. But that's the real, I guess, you could do that to a doctor as well. I mean, if you know what to say to get what you want. I mean, melatonin's probably a good example. There's lots of use of melatonin for jet lag, all age groups. But the S3 indication for melatonin is very narrow. So, conceivably a consumer could walk in and say, they want a young person wants melatonin for jet lag. They're planning an overseas trip. They could go into the pharmacy and say, "Look, I'd like to, get some melatonin. It's for my mum. She's, you know, she's having trouble sleeping. She's over 65. She's blah, 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 blah. Now, the pharmacist may decide, because they know you or you live in the area or whatever, to give it to you on the strength of the story you've told them. Now, that, you know, that may breach professional standards, because the pharmacist is meant to decide about the patient for the product. But, you know, there's plenty of people who don't buy their own medicines, who for one reason or another can't leave the house or can't find the time, and they would send someone to buy that product for them. So, you know, the pharmacist, now, certainly doctors can prescribe off label. That's within their professional remit to do that. I'm not sure about pharmacists, but if you wanted a way around it, then, you know, that you take you 5 minutes on the net to find out what story to tell a doctor or what story to tell a pharmacist. So.
Just on the back of that, one of your slides had a prediction, which I won't hold you to, as to where the market's going, but you did have a little slither there for e-stores. So
Yeah,
how does that work in the context of somebody anonymously sitting behind their computer, reading the scheduling? If they want to go to that extent to go, I have exactly this.
it's complicated, and it's not a CBD specific problem. I mean, if you have a look at the Chemist Warehouse website, and I spent a bit of time mucking around there in preparation for this, and you'll see their S3 products don't have a picture. S3 non-appendix H, they don't have a picture of the product even. They just have like a shopping bag sort of icon or something, and you click on it and you can add it to the basket, but you have to talk to the pharmacist first, or the pharmacist will verify it in some way. Now, that's entirely appropriate. It's entirely consistent with the requirements for you to be able to buy S3 products online, but the pharmacist does get involved in the transaction. And yeah, I mean, without a camera, how are they going to know if you're a, you know, 30-year-old man or a 60-year-old woman or an 85-year-old man? They're not going to know that. So,
Or a 17-year-old in the case of
absolutely,
this
yeah,
particular.
yeah.
What consideration does the TGA, like, you know, on what basis does the TGA determine whether a product is included in Appendix H or not? And what evidence do they like to see to change whether a product is in Appendix H?
Yeah, that's a good question. And that's a hard question too, because so for a long time, the default position was no Appendix H. So you come down from S4 to S3, and you only got into Appendix H if you convinced the committee and the delegate that you are worthy of being there. The onus has been reversed, you know, and thanks to work done by ASME, and said that's that. So now when you come down from S4 to S3, you automatically go into Appendix H unless someone raises a suitable objection. Now, I don't know what that suitable objection is. I mean, our submission on the topic, and I think consistent with a number of other people, was there is so much misinformation about cannabis and CBD readily available. Why wouldn't you permit sponsors to talk about the products in a way that is controllable, in a way that they can be punished if they don't do it properly? I mean, what better way to counter all of that misinformation than to permit legitimate advertising? But for whatever reason, the delegate decided that the risks were too great. It wasn't in the public interest, and that he would overturn, or he or she would overturn that that presumption that you go into Appendix H. Now, put in an application, you know, predicting what the ACMS will do is fraught business. But what I do know is that it doesn't have to be a massive dossier. It doesn't have to be a huge, complex, clinical, data-based argument. It can be pretty straightforward. And, you know, even my understanding is that for the recent triptans down scheduling, that was based on, you know, a fairly concise argument that if you've got migraines and you've had them diagnosed and you know that they're migraines and you feel a migraine coming on and you're out, why shouldn't you just duck into wherever the nearest pharmacy is, grab 2 tablets, take it, and you're fine. You know, you don't have to carry your prescription around with you. And that sort of made sense, you know, and that got up. It had support from the professionals, which is always helpful. So yeah, I mean, if you can put together a cogent argument and generate a range of support, especially within the healthcare professional community, then you might succeed. But you know, you look at other examples of, you know, the erectile dysfunction products, for instance. Now, there's been, I think, 4 submissions made, and in the UK, the UK government has said it's fine. Sorry, make it OTC. It's no drama. New Zealand, not quite open OTC. There's a little bit of a protocol for pharmacists to follow, but the decision here was no, it stays S4. And I don't know how much more data you need than 2 comparable markets successfully managing it as an OTC. So yeah, it's very difficult to predict the outcomes, but yeah, a good argument, well supported, I think is the best approach.
And short follow-up question: are there instances where some brands of products are included in Appendix H while others aren't?
No, okay. It's substance-based, so that'll list, you know, paracetamol, low-dose CBD, ibuprofen, whatever, will go in there. And so yeah, that's the other trick, is that if one person does all the work, everyone else will benefit. So.
Steve, when you looked at the market segments, and pain was 700 odd million, sleep was about 115, I think, and then we had the stress anxiety, it was the lowest. The pain's a really well-developed market though, isn't it? With
Yes.
really effective products with the Voltarens and the Nurofen and the Panadols, etc.
Yep.
The sleep, you know, I'd say there's not really a lot of good effective products in that category. So maybe the segment could be larger with something that worked better, maybe,
Yeah.
and similar with the stress anxiety. All those complementary medicines haven't had to prove efficacy, and the challenge is mild anxiety. How do
Yeah.
you prove efficacy
Yeah.
with something that's really mild?
Yep.
But maybe
And-
that's
and-
why OTC didn't work.
Why would you spend a fortune developing a clinical study on, you know, Carver, when the moment you publish that, everyone else gets a free ride as well, which is, you know, this tension between there being insufficient data and there being no incentive to generate that data. So yeah.
Except
yeah.
with CBD, you know, you've got a herbal extract versus the isolate we're talking about, and then people see there's a feeling that there's this entourage effect of having
Yeah.
the other terpenes and cannabinoids and that sort of thing. So, you know, you may be able to get a product specific argument,
Yeah.
but you have to prove it.
And yeah, I mean, I guess the question is, you know, if you are entering any one of those 3 segments, are you going to grow the segment, or are you just going to pinch market share from the other players? And I guess that depends on, you know, unmet pain needs, and it depends on, you know, prescription, because there's also those categories also have prescription medicines that people may be taking now, and that they might prefer a low-dose CBD product to the prescription medicine they've got.
Are there any OTC products on the PBS?
A very small segment. There was a concerted effort some years back. I'm not very good with dates, but at least 4 years, maybe more, a concerted effort to get rid of all the OTCs from the PBS. And one of the big casualties there was modified release paracetamol, I think. There are still some very small things, and I think that it's pain, it might be smoking cessation, and they might be for very specific patient groups, like maybe some Indigenous groups, maybe some other specific, maybe veterans, but yeah, it's tiny.
Yeah, look, former Norgine employee, our Norgine product Movicol is on the PBS, and that's an unscheduled
Okay.
medicine, been on for a long time.
Okay.
It's pretty much,
And
it's
is
got a
that-
very broad restriction.
Okay, and is that for the general population?
Chronic constipation, yeah, adults and children.
Wow. Okay.
So
good.
it's they maintain that broad listing, and it's quite heavily prescribed.
Okay. Good. No further questions? Oh, okay. Good. Thank you. Thanks a lot. Thank you.